Hello everyone. So we are here to discuss the FMG recall. How was the paper? First of all, how was the obstetrics and gynae paper? A lot of questions were asked. I must say it was many of the questions. 80% questions were very straightforward and easy. You might have marked them very easily. 20% of questions might have got confusion to you. Some were confusing and some were actually little tough. But overall, it was a mixture of good questions. None of the question I would say was very irrelevant. कोई question ऐसा नहीं था that I will say कि ये कैसे आ सकता है. Every question was relevant, and the standard of FMG has really improvised. That is gonna help you a lot, because now if you have passed this FMG exam with good marks, it means your preparation for NEET PG is already very good. It means you are already one step ahead of those preparing for NEET PG. You are already ahead of them. So good. Now let's start with this recall. First question. Right. Endometrial hyperplasia without atypia. Without atypia. So hyperplasia is So endometrial hyperplasia is a cancerous condition, obviously. Is a pre-malignant condition where the cells are hyperplastic. The thickness of endometrium increases a lot. If it is not controlled, it can eventually turn into endometrial cancer. Definitely, we have to treat it. Now, question depends on with atypia and without atypia. So when it is with atypia, the chances of cancer are even more, and then the treatment will be basically hysterectomy. But when it is without atypia, then thankfully medications can work. We have discussed many times in our classes that the prevention of endometrial cancer is progesterone. When you give progesterone, any condition that has a risk of endometrial hyperplasia or a patient who has endometrial hyperplasia, you give progesterone, that can protect you from cancer. So here the answer will be LNG IUS. Obviously, these two are out of question. Some of you might think, why not COCs? So COCs also, if somebody has irregular cycles, if you give them COC, the growth of the endometrium is limited. True. But again, because of the progesterone content in it, it is the progesterone which limits the growth of endometrium. So those who are not very interested in taking Mirena, yes, COC might be an option. But the correct answer, the actual treatment is Mirena. Okay. Identify this sign. We have multiple times done the early pregnancy signs. The bluish tinge of vulva, vagina and cervix is called as Jack-Mayer's or Chadwick sign. Very easy. Okay, sign of early pregnancy. Another sign was asked with this image. If I'm not wrong, we have done this also. I have told you, when there is an image of bimanual examination, one hand in the vagina, one hand in the abdomen, trying to approximate. They are approximating each other, just like the letter H. We have discussed this, isn't it? So when two hands are trying to approximate in middle, they are not approximating above, they are not approximating down below, but in the middle, due to softening of the segment, this is called as Hagar sign. If the similar image is asked where the two hands are there, but they are not meeting each other, they are just trying to cup the uterus in between them, they are trying to hold the uterus in between, something like that, that would have been the Palmer sign. But here, when they're approximating, it is Hagar sign. Earliest sign in pregnancy. Again, a repeat question. When does G-sac is visible? That we have done at 5 weeks. Yolk sac, 5.5. Fetal pole, 6 weeks. After that, cardiac activity. So obviously, the earliest sign is 5 weeks. G-sac. If the question would have been, what is the confirmed sign of intrauterine pregnancy? G-sac ka hona is not a confirmed sign कि pregnancy अंदर ही है, because it might be a pseudo G-sac. So the confirmed sign of intrauterine pregnancy is yolk sac. But the question was the earliest sign. Earliest among them is G-sac. सबसे पहले बच्चे का घर दिखेगा. The G-sac. Then the fetal yolk sac will be visible. And then the fetal pole will be visible. Okay. Vaccine that is not very good in pregnancy. We already know that live vaccines we can't give in pregnancy. Live vaccines are contraindicated, except one live vaccine that can be given, that is yellow fever. Yellow fever is the only live vaccine that can be given. So what all we can't give? We can't give measles, mumps, rubella. We can't give a vaccine of varicella. They are the live vaccines. So which of these vaccines we can't give? This one. Influenza may be. Once some strains are killed vaccines and some of these vaccines are live vaccines. So influenza killed vaccine we can very well give. Patient suffering from hirsutism, ultrasound showing string of pearl appearance. Very, very straightforward. This kind of appearance, I told you, when multiple small cysts are there, multiple small cysts in the periphery, obviously PCOS, not OHSS. We have done this multiple times. OHSS is big, huge cyst filling the ovary. That is OHSS. A girl comes to you with complaint of irregular periods. So irregular periods with excessive hair growth. So can we understand the pathology? Yes, most likely it is PCOS. What is the first line? PCOS में hirsutism का treatment of choice is OCPs. But PCOS में first line treatment, we have always said, the first thing that will you advise for any PCOS patient, no matter उसकी complaint क्या है, no matter what her complaints are, the first line of treatment is always lifestyle measurement. When you ask her to control her weight, if she loses her weight by 5 to 10%, majority of the pathologies get resolved. So the first line of treatment is this. Of course, it's not the treatment of choice, but it is the first thing that you propose. Ovarian drilling. So I've got to know this question was not there. Okay. Which surface of placenta has been shown here? This surface. So placenta is made by contribution of a fetal part and maternal part. Okay, so fetal and maternal both will contribute. So where the fetus is, fetus को अपना blood supply कैसे मिलता है? Through placenta वो कैसे लेता है? How it takes the blood? Through the umbilical cord. So the part where umbilical cord of the fetus, so if this is the fetus, if suppose this is the fetus, this is the placenta, somewhere here is the maternal part, it is attached to the placenta via umbilical cord, right? It is attached, it is the villi. So the part where the umbilical cord is attached is the fetal part, smooth, shiny part because of the membranes, and the umbilical cord is attached. That is the fetal site. Whereas the one where the cotyledons are seen, you can see this kind of image, rough with big cotyledons, no umbilical cord attached. That's a maternal site. Also called as decidual plate, basal plate. They all are same. Okay, so because it is made from decidua basalis, we also called it decidual plate. Okay, so that is the maternal part. In cervical cancer, which kind of radiotherapy is used? We know the cervical cancer may in the early stages we use only the surgery. And after 2A, starting from 2B, we have to use chemoradiation. So we have to combine the chemo radiation. So radiotherapy is backed up by chemotherapy. So it is chemoradio that is given. And in genital cancers, the chemotherapy that is always preferred is platinum based. Even when you give chemo in the ovarian cancers, and here also it is the platinum based chemotherapy that is used. OCPs, okay, if you might not have answered this question, some of you might not have asked, then also it is okay. Okay, because generally we don't go into too much depth of the chemoradiotherapy at the undergraduate level. OCPs do not prevent the following cancer. So OCPs prevent 3 types of cancer. Ovarian cancer, it is the only chemo prevention. Ovarian cancer का अगर कोई chemo prevention है, then that is OCPs. Also, I told you endometrial hyperplasia में the treatment of choice is progesterone. But OCPs अगर आप दे दो, then that will also be helpful in case of endometrial cancers in prevention. Also, one we have read is colorectal cancer. In colorectal cancer also, it is very helpful in preventing it. The only cancer where it will not prevent the development of these malignant cells, in fact, the OCPs will be contraindicated, is breast. In breast cancer, anything containing progesterone, be it injections, be it implants, be it OCPs, everything is contraindicated. A patient had forceps delivery few hours back, after which she had severe pain. On examination, there is swelling of vulva and bluish discoloration. It means definitely she has a hematoma now. So patient also showing signs of hypotension and tachycardia. Okay, now it means it's a big hematoma. She is losing a lot of blood. What will you do? Will you resuscitate and take her to OT? Yes. Will you transfuse her blood? Definitely. Will you inform your seniors? Yes. Will you remove the suture while being in the ward? So it is a hematoma. It's a great severe injury. You need a lot of helping hands. You need good light. You need OT help for the repair of this hematoma, for controlling the bleeding. You might have to go far above doing internal iliac ligation. In case the hematoma bleeding is not controlled, you might need to do laparotomy also. So definitely you will not do anything in the ward. You will resuscitate her in the ward, transfuse blood, and you will take her to OT. Okay, for such a big hematoma management. So this thing will not be done. What is this CTG pattern? So if this was the image, that with the contractions, you have to see peak to peak. If the peak of contraction is matching the peak of deceleration, if it is matching, that is early deceleration. If your peak is not matching, this is the peak for contraction and the peak for deceleration is this is not matching. Okay, this is not matching, that is late deceleration. If suppose contractions are coming at whatever speed and the deceleration is happening at their own speed, they have no relation with each other, that is variable. So as what I have got in the recall, it was mostly early deceleration. Antihypertensive contraindicated in pregnancy. So we have, when we read pregnancy induced hypertension and other pathologies, we read that the drug of choice is labetalol. What did the second choice I told you? I told you will go for nifedipine. What was the third choice? Methyl dopa. It was all in a non-emergency condition. In emergency, I told you labetalol will be the drug of choice. It's only that we will give it IV. Then, not controlled, give her nifedipine. Still not controlled, I told you methyl dopa is slow acting. So in emergency conditions, we will use hydralazine. So these were the drugs which are used in pregnancy. Did anywhere I mentioned ACE inhibitors, AT antagonist? No. In fact, a woman who is chronically hypertensive, जो पहले से hypertensive है, many times they are taking ACE inhibitors and AT antagonist. We have to stop them because they can cause renal artery stenosis. They can cause renal abnormalities. That is why ACE inhibitors are not given in pregnancy. Okay, these all we have read multiple times that they are given in pregnancy. Home-based pregnancy test, the kit that we used detects what? It detects beta HCG. So this was an image-based question that was asked. Hormone responsible for this action, where mother is feeding and the baby is sucking the milk. So what is happening here is milk ejection. So they have not shown milk secretion or milk synthesis, milk ejection. When the milk ejection, that is galactokinesis. Remember the 4 steps involved in lactation. So milk ejection, that is galactokinesis, is the function of oxytocin, right? There is no confusion in this. Following vasectomy, the man is advised to use additional contraception. Why? Because once you have done the vasectomy, ये जो testis है, here is epididymis, then the vas difference, then it goes to the forming ejaculatory duct and everything. When the vas difference has been ligated here, then there is a lot of sperm still left in the system which need to be removed. Okay, if they are not removed, men is still fertile. It takes approximately 20 ejaculates and 3 months. So approximately 3 months happen when this all is flushed out. So after 3 months, we ask husband to give a semen analysis sample, and when that shows azoospermia, then we declare that man as infertile. Good. Then I'll take it. Then we'll advise that man that now you are infertile. So the duration is 3 months. Now next time this question can be asked in form of ejaculate, so it is 20 ejaculates. So after 3 months we need a semen analysis, then we can declare him as infertile, right? Which of the following hysterectomies are safest in respect to ureteric injuries? Yes, we have done this also. Ureteric injuries can happen in case of hysterectomies. The highest risk is that in the Verdheim's hysterectomy. The type 3 hysterectomy, which is the radical hysterectomy, has the highest risk. Obviously, radical मतलब आप uterus और उसके आसपास का सब कुछ हटा रहे हो. So when you are removing everything around the uterus, ureter might get involved. That has the highest risk. The least risk is in case of vaginal hysterectomy. When you are doing it vaginally, the uterus is pulled out. It is already coming out. You pull out and you cut it. The ureter will not come out. Ureter will stay at their place. So the least risk of ureteric injury is in vaginal hysterectomy. Okay, not in abdominal, not in laparoscopic, not in robotic. Vaginal hysterectomy has the least risk for ureteric injury. Now, a patient with history of difficult labor and cesarean section presents with dribbling of urine. Why she has come with dribbling of urine? So obviously it is a case of vesicovaginal fistula. A fistula has formed between the bladder and the not ureter and the vagina. Vesicovaginal. So the most common cause of VVF in our country is this only, the obstructed labor, right? Whereas the most common causes of fistulas in the Western countries is surgery, okay? Like abdominal hysterectomy, what we just read. So obstructed labor is the cause of urinary fistulas in our country. And what kind of fistula form? When there is obstructed labor, क्या होगा? Baby will be stuck in the vagina. Vagina में baby stuck हो जाएगा for long. So when the baby is stuck in the vagina for long, necrosis of the vaginal wall will happen and it will combine with the bladder wall ahead, resulting in vesicovaginal fistula. Why is it not urinary retention? It might be that abhi usko deliver hui hai, she is in so much pain, there will be urinary retention resulting in dribbling, what we call overflow incontinence. वो क्यों नहीं हो सकता? Because possible है, हो सकता है because of pain she is not able to pass urine and it will start overflowing. इसी को overflow incontinence कहते हैं. But क्यों नहीं है? That will not happen on day 7. Day 7 पे थोड़ी ना उसको इतना पेन होगा that she is not able to urinate. So overflow incontinence will not present that late. And presence of history of difficult labor indicates a fistula formation. What is the characteristic feature seen in ectopic pregnancy? Ectopic means pregnancy outside uterus. So what will be there in the uterus? Endometrium will not get thick, it will be thin endometrium and the adnexal mass will be seen. Okay, that is very typical with fluid in the pouch of Douglas. So that is the answer. Again, it's a very straightforward question. What is abnormal heart sound in pregnancy? In pregnancy, a lot of heart changes happen. The apex the apex bead shifted outside, and then there is suddenly a lot of blood volume increases, the blood pressure falls. So a lot of heart sounds start appearing in pregnancy. Soft systolic murmur are very common. Systolic ejection murmur. When the heart is ejecting the blood out, there is so much blood in this heart, it is ejecting it out forcefully, resulting in systolic ejection murmur. Also, S1 and S3 are common sounds that can be heard in pregnancy. Many times breast shuffle is heard in pregnancy, mammary shuffle, that is confused with some heart sound. So systolic ejection murmurs is because of lot of blood being ejected out. That is common. S1, S3 are common. What is not common is diastolic murmur. And if it was written mid-diastolic murmur, then it is even more specific. Mid-diastolic murmur is characteristically seen in mitral stenosis. It is seen in mitral stenosis. So when the heart is dilating, then if you are listening some murmurs, especially mid-diastolic, that is not a normal physiological change of pregnancy. Systolic ke time pe murmur aa rahi hai, that is because of lot of blood being pushed out, that is normal. Okay? So diastolic murmurs are not seen in pregnancy. This is the answer. Identify the procedure. What is being done? Can you see a big balloon is being inflated in the uterus? Why will we do that? Why we do that? For any cervical dilatation के लिए use करते हैं, but उसमें इस balloon को we inflate. Cervix पे inflate करेंगे and then we will pull it. हमने इधर पूरे uterus में balloon inflate किया है. So what we are doing is balloon tamponade. We are doing intrauterine balloon tamponade. Why it is not endometrial ablation? Endometrial ablation में we don't use such a balloon. We use either a metallic ball or it is done using some laser where we burn the endometrium. It is a whole balloon which is inflated. Can you see something like that? Most likely catheter is being used. So it means it is not some metallic balloon. It's a catheter plastic balloon जिसको आपने saline से inflate कर दिया है. So it is intrauterine balloon tamponade used in PPH. Shoulder dystocia. Whenever we start our topic of shoulder dystocia, how do we define it? Head has come out, but the body does not follow even in 1 minute. So when the body does not follow even in 1 minute, that is shoulder dystocia. Where is this instrument contraindicated? जैसी इमेज देखी होगी सोचा होगा अरे ये तो we know. This is a previous year question. It's an outlet forceps. But now see the option. They are asking where the forceps is contraindicated. Not even outlet forceps. The question is where is obstetrical forceps contraindicated? Do we use it in breech? Yes. For delivering the head, we use forceps. Not this one, but we use forceps. है ना? For occipito posterior position, yes. We use rotational forceps, isn't it? Definitely we use it. Cesarean section. In cesarean section, when the head is deep down, we use one blade like a vectis. Vectis मतलब like a big spoon. We जैसे कि head है, it is stuck, we use it like a vectis, उसको head के नीचे डालते हैं and we take it out. So yes, it is used in cesarean section. But in obstructed labor, do we use any kind of forceps? Do we use any kind of vacuum? अगर patient obstructed labor में है, या फिर CPD भी लिख सकते हैं, अगर patient को cephalopelvic disproportion है, can she deliver vaginally? No. If she cannot deliver vaginally because there is disproportion, we cannot use any instrument. हमें cesarean करना पड़ेगा. So these instruments are obviously contraindicated in any patient जो vaginally deliver नहीं कर सकती. Patient को placenta previa है. So is it a contraindication for the instrument? Yes. She cannot deliver vaginally. Why will you use them? So answer is obstructed labor. Right? Then the fetal anemia is monitored by, whenever there is fetal anemia, if you have not answered to this question, then also acceptable. If you have read RH incompatibility very clearly, तो आपको आता होता, अगर पढ़ा होता तो, because the thing is RH incompatibility का management हमेशा पूछा नहीं गया. In FMGE it has not been asked the management, so some of you might not have marked it correct. So RH incompatibility में when there is fetal anemia, how do we judge? Baby तो अंदर है. We are not taking blood sample from the baby to know it is anemia. How do we do it? We have to use some non-invasive method. So we do ultrasound. Because we know whenever there is anemia, the body try to save the most vital organ. Body कोशिश करती है सबसे vital organ को बचाने के लिए. So that is brain. So suddenly when the hemoglobin is falling, the brain is the one which needs most oxygen. Lot of blood starts pouring into the blood vessels of the brain. Why? Because hemoglobin has fallen, so lot of blood starts going into the fetal brain. So what happened? The middle cerebral artery, अगर हम measure करें, उसका peak systolic velocity is rising. So rise in the peak systolic velocity of middle cerebral artery is showing that a lot of blood is going into the brain. And why is it happening? Because the baby is getting anemic. So the body is trying to save the brain. So for fetal anemia, we use middle cerebral artery. That is the most accessible, a very early vessel that will show us the sign and very easily visible in ultrasound. So that's what we use for fetal anemia. 46XXP57KIP2 negative indicate what? If you have not answered this also, acceptable. It is basically immunohistochemistry. So basically when we want to differentiate between complete mole and partial mole, the diagnostic test is histopathology. But these days immunohistochemistry is also used. What is the whole basis here? That this P56KIP2 gene is located on chromosome 11 and it is represented by the maternal allele. So we have, all of us have two chromosomes. One we have got from our father, one we have got from our mother. So the one we have got from mother, that maternal allele, is the one that is representing this gene. So are we all P57KIPT positive? Yes. अब molar में क्या होता है? In molar pregnancy, this empty ovum मतलब maternal genome is not there. It's fertilized by two sperms. So obviously the chromosome makeup is 46. Okay, it can be XX, it can be XY. But this gene, since there is no maternal chromatin, है ही नहीं, this gene will be negative. Whereas in partial mole, a normal ovum which has maternal genome also is fertilized by two sperms. So genetic makeup will be 69, XXY, maybe XXX. And P57, इसको हम लिखते हैं KIP2, positive, because it has maternal genome. So it is the complete mole where this gene is negative. Okay? If you have not marked this correct, that is okay, that is acceptable. So this was all about the questions. If I have left any question, yes, a few of the students have sent me, just wait a second. Yes, that the identification of pouch of Douglas also came and an open neural tube defect. So obviously I think you all might have marked it correct. The pouch of Douglas is the most dependent part in our body. So this is bladder, this is rectum, in between the peritoneal fold, that is the most dependent part is pouch of Douglas. Right? So this was the all FMG recall, all the questions that I got. Hopefully आप लोगों ने अच्छा किया होगा. The questions were amalgamation of the little complex and the easy one. Let's keep our finger crossed and let's wait for the big day. Meanwhile, enjoy your hard work and enjoy these free days. Bye bye.